Are live.
Yay! Hi, everyone. Welcome, welcome, welcome to day two, session two of Health Equity Week of Action, HEWA for short. We are so thrilled to have you returning to us or joining in either here on Zoom or on our live streams, because we're fancy like that, to come and learn more about minority stress and racism in medicine here with us tonight. Now, before we get started, I want to take a moment to orient us back to the framework. The framework of abolitionist medicine, the framework of a call to action, is how we have designed this week. We've thoughtfully chosen speakers and presentations and toolkits that we feel do the best job possible of helping us to orient around what abolition can look like. Now, if you haven't heard that word much, and it's okay if you haven't, it really means that we are fighting back on oppressive systems of harm. We are bringing narration and storytelling, and we're bringing honest truths and accountability to systems of oppression, of racism, of harm, of violence. And we're doing so with love, with compassion, with what I mentioned in our last talk from the lovely Brene Brown, with a firm back, a firm spine, and an open heart. A firm back that is willing to understand the boundaries that we will have to push as AMSA lovers and as clinicians and future clinicians out in the world, and an open heart for some of the unconscious and conscious systems of harm that have resulted in the oppression and stigmatization of minority populations. We are looking to call out, yes, but we're also looking to call in. We want to give you a place to land. So in collaboration with AMSA's Code Blue, which is a movement in response to our political climate, if you will, a response in uplifting one another and providing a harbor safe from the storm, where like-minded soul friends can connect and can advocate with alongside one another, hand in hand, against the harm that we are seeing aggregating every day. So a part of that advocacy is here at HEWA. I want to take a moment to thank the lovely REACH committee. Many of them are still joining. Just to name a few: Tanushri, Stephanie, Mia, Michaela, our wonderful scholar programs, everyone on staff, and the amazing Jeff, who is here tonight, who I want to take a moment to say hi as well, if you so will.
Hi, everybody. Good evening, and it's great to be with you all in the second session, second day of HEWA. Danya, thank you for the work that you've done on this and for thinking along with your counterparts in the race and ethnicity and culture and health action committee to think about how we can address health inequities by not just talking about what the data is, but by really looking at what the root causes are, and to go to the root cause of things, which is why we use the word radical when we're talking about things like this. To go to the root cause is to acknowledge that these are systems that don't actually require any one person to be in the room in order for them to continue to run and to cause harm. And when we say things like the system is broken, we're actually misunderstanding what the original design of the system was for. So we can say the system is actually working exactly how it was designed and getting the outcomes that it is intending to get, but recognizing that the system was designed for a kind of set of outcomes that are fundamentally unjust. Mm-hmm. So that's why we're here. We're here to talk about why we are, why do we recognize, why do we see this data that reveals the inequities in health outcomes, the inequities in lifespans, the inequities in quality of life. It's not because some people are more or less deserving, it's because the system has deemed that there are people who are more or less deserving. And we can't abide by that. As a profession that claims to, that makes the claim as its first ethical principle, do no harm, we have to take seriously where we participate in systems of harm, and to figure out how do we disentangle ourselves from them, and to actually be forces for good, for justice, for fairness, for reparations.
Mm.
So thank you for all the work that you've done to put this together.
Thank you so much, Jeff. Thank you. Thank you. That's beautiful. And I love the word reparations. And that's what we're looking to do all this week, looking at not just inequity, but the roots of inequity. And we do that through thoughtful conversation around subjects that deserve our complete attention, like minority stress. So, in our previous talk today, we mentioned a little bit about this, how systems that enact trauma lead to distrust, which leads to poor health outcomes, which then clinicians question why poor health outcomes exist without looking in the mirror at the ways in which we might be participating. We need to look closely at communities and respond to their needs. So, without further ado, I'm so excited to be presenting you with the lovely Dr. Chase Anderson, an assistant professor at UCSF, a psychiatrist who leads in the world with vulnerability, who is quite honestly one of the most comforting and easy to speak with physicians I've ever met, alongside Jeff. Someone who fights for mental health for children, someone who fights for minority populations, someone who fights for LGBTQIA health, someone who we can lean on to learn from, and who is doing the work that we are so boldly, working to meet the standard we're hoping to meet. So thank you, Chase, for your time, Dr. Anderson, for your spirit, and please take it away.
Thank you for that introduction. You're going to make me cry before we even get started. Just very fortunate to be here with all of you. So let's do this. All right. In terms of disclosures, I truly have no disclosures. So we're going to move on from that. What we'll be talking about today is minority stress in the medical professional. So how minority stress affects mental health. In terms of an overview, part one will be a personal vignette to bring you into the story and how minority stress can affect people. Part two will be what is minority stress, so some definitions. Part three is minority stress in America and in healthcare. So you have statistics. When people say minority stress doesn't exist, you can be like, it's been researched. Here are some statistics. Part four will be how do we help and how do we grow? Part five is how can minoritized people protect themselves? And part six will be a personal vignette revisited. In terms of learning objectives, at the end of this presentation, learners will integrate into their practice the ability to specify at least 3 ways in which minority stress affects mental health, assess how minority stress can affect minoritized trainees and faculty in the medical system, and identify at least 3 ways in which we can make academic environments safer for minoritized individuals. So let's start with that personal vignette. My life changed when I came out at age 12. Until then, overall, I'd lived this idyllic little life, one where I was educationally and economically privileged in ways I didn't even know at the time. I hadn't heard the N-word yet. I knew the world was hard for gay people from newspapers, but I didn't fully grasp how things were about to change. Through the next years into high school, I was called the N-word, homophobic slurs, and I went through bullying because of facets of my identity. Even though I was one of the top students, even though from the outside, many people thought I lived this perfect little life, even though I made it look good, people didn't know that my smile hid so much. I didn't know what to call it at the time, but I began to develop depression and anxiety. I feared going to school even though I loved learning. In high school, because of discrimination I faced, I had 1 suicide attempt. No one knew I wasn't hospitalized. My mom, dad, and sister helped me survive during those years in various ways, even as I hid my depression. Then I entered college at MIT and my life changed for the better. Not at first, though. Within the first few weeks, I was rejected from a fraternity because I was open about being gay, had to meet with MIT faculty about it, and subsequently failed all my first exams because I developed panic attacks for the first time. I was no longer a stellar student. I also was sure I was going to fail out. This led to my second suicide attempt. Again, no one knew. I was ashamed to openly say what was going on inside. I thought I was going to end up dead. Yet, something different happened. The friends I had made at MIT validated my experiences of discrimination, shared their own experiences with discrimination and mental illness, and how they dreamed about changing the world. We bonded tightly together and we learned how to support each other. We saw each other as more than the characteristics often used to define us and shattered those stereotypes. We became a family where we spoke about topics of diversity regularly and shared our lives with each other. Because of them, I made it my purpose to help others not experience the same issues I had. I got to see what it meant to truly live. It wasn't perfect, and there were instances of discrimination, but it became more rare as time went on, and there was always nearly someone else besides myself who spoke up against such instances. Those friends saved my life. They helped me soar for the first time as I embraced my identity, and we celebrated each other's identities. Because of our friendship, because of my family, without meds or therapy, I entered what I later called the golden years right before grad school at MIT, a 2-year period where I didn't have a single depressive symptom or any suicidality. I thought my depression was gone forever. I left MIT with the certainty that America was ready for a shy yet confident Black, gay, introverted guy nicknamed Dream and a unicorn phoenix by his friends. Medical school, however, was about to disillusion me and bring back the one thing I thought was cured forever. I became class president at Northwestern in the first few weeks, and things became a slow descent into hell. I was told by a classmate that I won class president because I'm Black and gay. I heard how I talked about being minoritized too much. I started to get shut out and shunned, even from events I helped plan with classmates. 6 months in, my depression, anxiety, and suicidality had returned. Every day became about social navigation, balancing class president, finding allies, including our vice dean, educating people constantly about the discrimination they were enacting, taking on certain deans who had enacted discriminatory behaviors, making changes with others, handling schoolwork, and planning my escape from medical school. All the while, my identity fractured. I began to fail exams. I cried alone in my room at night and woke screaming from nightmares. I couldn't even tell my friends in Boston or family in Seattle what was happening because of the shame I felt and had been made to feel. Because of all of that, I started medications and therapy for the first time. Yet, even with meds, therapy, an abundance of friends in medical school, and alliances built, that didn't stop the flood of constant discrimination that continued to break me. I failed 4 shelf exams in a row. I had never felt and been made to feel more alone. This led to one night in 3rd year where I had plans and intent to suicide. After that night, there were several breakthroughs, including being more open with my friends in Boston about how bad medical school was, and I honored my surgery shelf and taught myself further tools to fully face down discrimination. However, I felt like a shell of a person who once dreamed of more. Although my psychiatrist, therapist, and I agreed, I entered clinical remission in my 4th year. My symptoms flared whenever I experienced discrimination. I couldn't figure out why my depression didn't fit the classic criteria we used in psychiatry, but that clinical remission was enough to hold me steady. I then matched back in Boston at a university where the program director said during interviews she hadn't heard about issues around being Black, but if there were issues, I'd be supported. I raced back to my friends in Boston, hoping to feel truly safe again. In residency, I saw the descent into chaos coming a bit better this time. For my psychiatry rotations for the first 3 months, I was told I was above where I needed to be. I thought I had found safety. Even when an attending, who was also minoritized, warned me that appearing confident and competent as a Black gay male would lead to discrimination and backlash, I thought that couldn't be true. Then, on my internal medicine rotation, I had an attending who kept pimping me in front of colleagues in a way that caused my panic attacks to flare. When I told her this, her questioning worsened. I heard how she'd done the same to other trainees. In the hospital, I was being called to the name of the only other Black psychiatry resident who looked nothing like me, asked if I was there as transport. My knowledge and the knowledge of other minoritized people was constantly questioned, and I was disparaged by some patients and staff and saw the same happen to colleagues. 1 week later found me standing at the sink in the hospital bathroom, crying before rounds, suicidal, having to force myself to go to work and not run away. On her evaluation, the attending said I was unprofessional, was worried about my being a danger to patients, and that my knowledge was far below my peers. Although other evaluations said I was above and beyond where I needed to be and praised my professionalism, my program leadership labeled me as unprofessional, rated my knowledge and professionalism below my peers, and I was ignored and told I was the problem when I told one of them what was happening in the hospital. I had to do a pseudo remediation with the internal medicine chief resident mornings after working overnights where senior residents said I excelled. Faculty had supposedly secret meetings about my not wearing a tie and how it was unprofessional. I rarely felt more stupid or embarrassed or that I was the problem. My suicidality worsened in frequency and intensity. Because of so many lived experiences, however, this time I knew what to do to survive. With my residency class, we strategized how to handle program leadership and make changes. Then we went to war with our program when we deserved peace and a safe training environment. I set aside the guy who simply wanted to date another guy and have a calm life in order to mentor others, push where I could with faculty, and support my colleagues. We led with vulnerability and used it as power as we spoke up constantly when all of us wanted to simply sit in quiet peace and dream upon the stars. This time around, I was open with my old friends from Boston and family in real time about what was happening, even as I had less time with them because I didn't have the energy. My colleagues set aside many of their dreams as we spoke up constantly and consistently. I restarted my antidepressant, which I'd been able to come off of after leaving medical school. I started therapy again. I wasn't just scared I was going to lose my life, I was constantly terrified as I watched my spirit fade. 1 year later, soon after one morning where my suicidal thoughts became more intense with intent, then I went on to have an attending tell me my work was excellent that day, which shows that we don't really know sometimes when somebody's suicidal. The same program director who hadn't listened when I told her how bad things were was crying as she apologized to me for how she hadn't listened, how she put me in a horrible position, for how she and the program had hurt myself and others. Then she and I got to work. Every week, we'd meet to discuss aspects of her identity, the program, certain instances of discrimination I'd experienced or classmates experienced. This was all on top of working to be the model minoritized physician. It didn't stop the depression, it didn't stop the daily discrimination I saw or experienced, but it did help to have a leader who validated myself and others who worked to better things. At the same time I was planning my escape from the program, I also began to speak out about experiences under a pseudonym on Twitter because I wanted other people to not feel so alone. When the co-program director, who is now an ally, announced she was going to another program, that solidified my decision to fast track to child and adolescent psychiatry. During interviews, I had better questions this time around because for minoritized applicants, it's not simply about, oh, this is a great program. It is about where will I be safe? Where will I experience the least discrimination? Faculty at UCSF were the most honest. I matched at UCSF. Then George Floyd was murdered, and people who had enacted discriminatory behaviors were rushing to apologize, invaded my space when I wanted to be left alone. Our program even said how they had hurt people, but never specifically apologized to anyone, and discrimination continued. We forgave because we saw it as people having blind spots and enacting learned behaviors from society, but that didn't stop the knowledge that the rush to assuage their guilt and these delayed apologies didn't heal my shattered heart or give me back the lost time, dreams, peace, or sense of self. So I geared up to leave. With plans to leave academia, fellowship was more of the same, began saying goodbye to my oldest friends and newer friends and mentors, wishing that the program had been safe enough for me to stay with my friends in Boston who I'd promised to be together forever with. So what does that all have to do with minority stress? So the typical definition is the process through which stigma directed towards sexual minorities influences health outcomes. This term came into being more in 2003 by Dr. Elon Meyer, who was looking at LGBT, or sort of lesbian, gay, and bisexual people. And back in the day, the thinking was that like queer people maybe just were more predisposed to having depression and anxiety and suicidality. What he actually showed and started to establish was that the reason that people who are queer have higher rates of depression and anxiety is because they experience this thing called minority stress. So out of that came the minority stress theory because a lot of other minoritized groups also noticed that this applied to them as well. So individuals from oppressed social groups experience excess stress and negative life events because of their non-dominant status or statuses, which can lead to or exacerbate mental health problems and physical health, they've proven as well. These effects are unique, socioculturally based, and long-lasting, which means they're additive. The way I describe it to the kids I work with is I say, think about getting one paper cut. That's like me being called the N-word at the beginning of the day. I can maybe patch myself up and put a Band-Aid on it. However, imagine getting 1,000 paper cuts per day. Then you're imagining basically that you're bleeding everywhere and you don't know how to put yourself back together. The other way I like to describe this is I watch Sailor Moon, and so she has this thing called the silver crystal, and the kids always resonate with this. So she has this thing called the silver crystal, and it basically is all of her shine and all of her power and her sense of self in some ways. So imagine getting a crack in that shine. You get one crack and it starts to leak light out all over the place. You get enough cracks per day and your sense of self shatters. That's what can happen to people with minority stress. This is the minority stress framework. And so we're going to go through it for transgender people, but you can use this to apply to racism, to somebody who's queer, all over. So at the beginning, there are these things called distal stress factors. I want you to think of these as external factors that affect somebody. These are things that America or other people have done to somebody. And so I always spin it that way for the kids. And that's why I say minoritized, because the kids did not cause these problems. It helps unlink them from thinking that they are the issue. In terms of external stress factors for transgender people, there's gender-related discrimination, such as not getting health care for being transgender, gender-related rejection from family and peers. There can also be gender-related victimization, so bullying or like physical or actual emotional violence because of being transgender, and then non-affirmation of gender identity. They've shown that using somebody's proper pronouns can actually decrease suicide attempts. All of these external factors can lead to physical and mental health outcomes, including worsened depression and anxiety, as well as suicidality. Sadly, this can also lead to internal stress factors. So the proximal actually can mean internal. So think about things that are inside of somebody. The reason this happens is somebody who's transgender may start out thinking, well, I know America's the problem. Like, we know America's a mess. However, if you get enough of these external factors, things start to become internal for that person. They start to basically gaslight themselves in many ways. So this can be things such as internalized transphobia, so actually hating other transgender people because they don't look like the right kind of trans person, or hating yourself for being transgender. This can also be negative expectations. So thinking that even if you meet somebody who is very supportive of transgender people, if you've had enough negative experiences before that, you might think that the next person you meet, even if they're wonderful, is going to think poorly of you for being transgender. There's also concealment for transgender people. This is also known as going stealth. So dressing and acting in a certain way to not look trans or to not have your trans identity be noticed. This can lead to also worsen mental and physical health. So there are also resilience factors, luckily, that were studied. And so I don't like to call them resilience factors because sometimes we blame people for not being resilient enough. So I call these strengths-based factors with the kids. The first is community connectedness. That's why I showed those pictures that I showed at the beginning. And for MIT, community does not necessarily need to be all transgender people. It can be anybody who is supportive of you and your identities, and that creates protection for people. There's also pride. So there is an outside force with community connectedness, and then there's an internal force with pride, and that means feeling centered in your identity and the facets of your identity. So how does this play out in terms of healthcare in America? In terms of racial statistics, a psychologist named Randy T. Lee looked at major lifetime discrimination. He noted that it was 48.9% for African Americans versus 30.9% for white people. It's high for white people in the study because they included women in that category as well. In terms of day-to-day discrimination, they noted that 44.4% of white people said they'd never experienced day-to-day discrimination. Only 8.8% of African Americans were able to say the same. This also sadly plays out in terms of pay discrepancies. So they looked at people who came in at the same entry level and had the same education, the same background. And they noted that 57% of African Americans versus 32% of Hispanic Americans versus 31% of Native Americans versus 25% of Asian Americans versus 13% of white people had been either passed over for promotion or experienced pay discrepancies. The slide is a little bit busy, but I want to draw your eye to the yes regularly column on the right. This means yes regularly having experienced discrimination. For white people, it's 3.82%. For Black people and every other racially minoritized category, it's higher. For Black people, it's 11.23%. For Asian Americans, it's 10.85%, and so on and so forth. In terms of studies for LGBTQ plus people, for LGBTQ plus youth identifying as LGBTQ plus openly, they look at studies across the biannually that are done across the country. So they look at different high schools. And so what they noted was all sexually minoritized adolescents reported higher rates of violence victimization. This included feeling unsafe, being forced to have sexual intercourse, being threatened with a weapon, being bullied at school or online. An example of this is in terms of bullying for gay males versus heterosexual males. They noted that gay males were bullied at a rate of 27.7% versus heterosexual males was 14.6%. So it's almost double. They also saw that the prevalence of cocaine, heroin, methamphetamines, ecstasy, inhalants, and other substances were higher in all sexual minority groups. And one thing I think about as a psychiatrist when somebody is using substances is that one of the best questions we can ask in psychiatry is why? Why is that person using substances? It destigmatizes things for them and reminds us that people use substances for reasons. A lot of the kids that I work with are using substances because they were not given coping skills to handle the minority stress that they were facing and the discrimination. And so sometimes they don't want to be inside of their body at that moment. This also plays out in the prevalence of suicide attempts. So for lesbian and gay people, it was 24.3% versus heterosexual people was 13.1%. The numbers on the right for heterosexual people will be a little bit different because it's looking at different high schools. For bisexual people, it's 28.3% versus 23.2%. And for people who were unsure, it actually the statistics reverse. And so it's 12.4% versus 14.9%. The reason that it reverses is that people who were unsure sometimes were able to blend in more and they weren't standing out in terms of like gay traits or stereotypically queer traits. In terms of drawbacks of the study, they saw high dropout rates and they also think that there's an underestimation going on. The reason they think they were underestimating the prevalence is because a lot of queer people develop their sexual orientation and identities earlier than their straight counterparts, which exposes them to discrimination much earlier. And so some of those people may have suicided or they actually have dropped out before they got to high school. And sadly, since the 2016 election, the FBI keeps track of hate crimes, and for every racially minoritized group and as well as for religious groups, hate crimes have gotten worse. So we have a lot of work to do. Some of the previous studies were, a lot of them were done for white LGBTQ plus samples. And so for Asian American sexual minorities, research has demonstrated that external racial stressors, such as among Asian American sexually minoritized individuals, result in greater psychological distress. A study done at the University of Tennessee noted that Asian American LGBTQ plus persons experience rejection, prejudice, and discrimination from the overall LGBTQ plus community. This happens to a lot of racially minoritized people who are in the queer community. So I cannot tell you the amount of times when I lived in Chicago and in Boston that on dating apps, I would get messages that started out with, "I love your black skin," or other things of that nature. So it happens on daily for people inside of their own communities. They also noted increased internalized heterosexism because of violating traditional Asian values such as harmony and complementarity. And among 314 LGBTQ plus people of color studied, 58 of whom were Asian American, they saw higher rates of depression, perceived stress, and need for acceptance. They also saw this thing called ethnosexual mythologies. And so that's fetishizing somebody by, like, it's fetishizing by a different name, which is kind of what I talked about before with dating apps and things like that. Along with this comes the need to talk about intersectionality. So this is the interconnected nature of social categorization such as race, class, and gender, which create overlapping and interdependent systems of discrimination and disadvantage or advantages. The example that I usually give here is that back in the day, my voice used to be higher pitched, and I actually had pitched it up for so long that I'd forgotten. And so what I was doing that for was because I noted that when my voice started deepening, I thought to myself I couldn't be a Black person who actually had a deeper voice because that would be more threatening. And so when I would walk by police people or like walk through daily life, I would pitch my voice up because it would be less threatening. So I figured out in therapy that my voice is deeper like it is right now, but for years I had forgotten that that was what I used to do for so long. Along with this comes the intersectionality paradox. So the thinking was that if African Americans were of higher socioeconomic status, maybe they would actually experience less discrimination. They've proven in studies that that's not accurate. Racism just changes in how it like comes against people. This also comes with the multiple jeopardy perspective. It's also known as the multiple disadvantages approach and also known as the multiple hierarchy stratification. So this is assigning low and high status traits for different facets of identity. I'm not going to go through it too much because I don't like this version, but it's just something you might hear about. Okay, so how does this play out regarding patients? In terms of microaggressions, so these are broadly defined as behaviors that ambiguously disempower racial minorities. That's actually an umbrella term, and there are subcategories inside of this. The first is microassaults, so explicit acts of racism saying someone is of lesser worth. The next is micro-insults, saying someone didn't earn their position. The last is micro-invalidation, so saying we are all the same. This also sadly comes along with healthcare microaggression. So these originate from something called aversive racism, saying we aren't prejudiced, we don't have racist tendencies. If we are born in America or we live in this world, in the society that we live in, everybody has biases. It's about naming them and then also saying, how does this affect myself and my relationship with other people? So, along with this comes this term called institutional betrayal. So, this is normalization of bad behavior, basically. The example for this is if a medical student goes to an attending and experiences discrimination, and then they go to a dean to talk about discrimination that they faced, how that dean responds will actually portend how the mental health of that person goes. If the dean blames the medical student, then their mental health will get worse. However, if that dean takes the attending to task and removes them from like taking care of patients or has them go through training, the medical student will actually feel more protected and their mental health will be better. So what we do inside of our hospital system is very important for medical trainees. In terms of patients, in 2017, Fitzgerald looked at vignettes and examined the influence of patient characteristics on attitudes, diagnoses, and treatment decisions. Nearly all, 35 out of the 42 articles, found evidence of implicit bias. This was bias around race, age, socioeconomic standing, mental illness, weight, having AIDS, patients who've experienced brain injuries, people who use intravenous substances, disability, social circumstance, and gender. They actually saw the same levels of implicit bias as the wider population. So if you took America and shrunk it down to the hospital size, you'd see the same rates of discrimination playing out. And when physicians were less certain of coronary artery disease diagnoses for middle-aged women, they gave women mental health diagnoses at higher rates compared to men. And intersectionality can actually play a large role in protection in the medical system. How does this play out regarding residents and other medical trainees? So in 2016, Lisi looked at bullying, so repeated acts or practices directed at one or more workers, unwanted by the victim, done deliberately or unconsciously, but clearly cause offense, humiliation, and distress, and may interfere with job performance and or cause unpleasant working environments. Examples of this were unjustified criticism, humiliation in front of colleagues, intimidatory use of discipline or competence procedures, undermining personal integrity, and shifting goalposts. Shifting goalposts is this thing where if a medical student goes to an attending on the first day and asks how to achieve honors, that attending will say, you need to do X, Y, and Z. Then the med student does X, Y, and Z flawlessly. Then the attending will say, you need to also do A, B, and C along with X, Y, and Z. Then the med student does X, Y, Z, A, B, and C. Then the attending will say, you need to also do D, E, and F flawlessly. That person is moving the goal line so that med student will never achieve honors. 69.8% of residents in the US have experienced workplace abuse, and the most common form of abuse was verbal in nature. In terms of types of resident mistreatment and themes that they saw hierarchy. That's why I tell everybody to call me Chase. We can't fully get rid of the hierarchy, but we're trying to flatten it as much as possible. They also saw silence, incognizance, fear, with 79% being afraid to report, acceptance and denial, and legacy of abuse. The legacy of abuse is if a medical student is mistreated or a medical trainee, they are more likely to become an attending supervisor who actually mistreats other medical students. So there's actually a sequelae of resident mistreatment that plays out on the individual and systemic level. First, there's a cost to the system with higher rates of medical errors, harm to patients, and dissolution of care. 67% who witnessed disruptive behavior felt it contributed adverse events for patients. And there's a cost to the system with higher burnout rates, thoughts of desertion, depression. They also are looking at studies that show that people who go through medical training can have post-traumatic stress disorder, substance use, and suicidal ideation. 20% said they would not pursue medicine again, and several would advise others not to pursue. So we have a lot of work to do. Unsurprisingly, for minoritized trainees, the medical system is worse. So Justin Bullock, who's wonderful, and you should all read his work, he talks openly about being Black and queer and living with bipolar disorder and being a physician. He's a nephrology fellow at UW right now and is amazing in every way. In 2020, he looked at minoritized fourth-year medical students who experienced this thing called stereotype threat. So stereotype threat, I think of as the other version of minority stress, where stereotype threat is an internal thing of you do not want to fit stereotypes that other people might have. So it's an internal process that becomes external and changes your behavior. They also looked at supervisor biases and possible poor prior academic training. They saw that stereotype threat can be triggered by being seen to stand out. And so when I enter a room, I'm actually looking around for how many other African American people are there? How many minoritized people are there? Are there visible signs of queerness where I know that this place is safe for me? I am more secure now where I just go into a room and I'm like, I'll do what I want. However, that took years. And so a lot of medical students don't have that like privilege that I do as an attending now. They also saw that stereotype threat can be triggered by reliving past experiences. So even if you have a like rotation where everything is going well, if you've had negative rotations, you're more likely to go into your next rotation with negative expectations. And witnessing microaggressions caused by proxy trauma for people. They noted that non-white students receive less favorable medical student performance evaluations and lower clerkship grades as well. So how do we help and how do we grow? The first part to this is we ask. When I did this talk with one of my friends during residency, we were like, oh, you can just ask. And then later on, we both were like, absolutely not. Sometimes we do not want people asking us about this stuff. So what I do with the kids is when I first meet them, I ask about their facets of identity, and then I leave it for part of the conversation. Then I come back to it and I'll say, because you identified as Asian American and bisexual, we know that America is messy. That usually makes the kids laugh because they're like, yeah, we know America's mess. And then I will say, you don't have to tell me specifics right now, but have you ever experienced anything that has been around your facets of identity or parts of your identity that have caused you to feel more anxiety or depression? And so that gives them an out. And that's how I recommend, and that's how I do conversations with other people, is always making sure that the person does not feel an onus to actually respond. Because there are some days I do not want to talk about racism. I do not want to talk about what's going on in the world. I do not need to get articles about what's going on because I've already heard it from 20 other people. So just thinking about how do we respectfully approach these conversations and make sure people don't have to discuss things that they don't want to. We also need to educate ourselves and protect minoritized people. There's a danger of being false allies as well that needs to be addressed, where posting a black square to Twitter is very nice. However, what are the actual policies that we're changing in the hospital system? We also need to come at this from humility, from seeking to understand and truly converse, because we all make mistakes. I still make them with the kids, and I'm still learning. And so how do we openly have those discussions? We also need to believe minoritized individuals when they bring issues forward. So how do we heal? Lisi, this is one of the best articles, that Lisi 2016 article. They saw that education and awareness led to decreased bullying. So all of you just coming to this talk and learning a few new terms or having an understanding actually will lead to decreased bullying. They saw that team-based care at all levels reduced the hierarchy, and good leadership, no surprises, led to better prevention and protection and defined a better culture. They also saw that interphysician support led to better mentoring and fostering of community. And they also saw the need for confidential mental health services. So an opt-out system where people actually are already set up for a psychiatrist or psychologist, so they don't have to scramble if they are facing things. And in the worst case scenarios, they saw the need for exit strategies. And so when somebody is going through discrimination, how do we get them to a university that might be safer for them without backlash? We also need to recognize, name, and understand these attitudes and actions and identify our own implicit biases. They saw the need for diversity training, not just about diversity now, but what harms have been done to minoritized peoples like over the centuries, because we keep repeating patterns in a lot of ways. They also saw continued research or need for continued research for addressing patients' social risk factors and needs, and they saw the need for diversifying the healthcare workforce. This also has a caveat, because sometimes they think that universities will say, like, we'll bring in more minoritized medical students. If you bring those medical students in, you are then expecting them and forcing them to like change the system. And what happens is a lot of those medical students will leave. When you look at residency pictures or you look at like medical student pictures, then you look at how many people stayed for residency or fellowship or attendinghood, you will see that most of the minoritized people leave if the university is not safe for them. So how can minoritized people protect themselves? Thank the goddess Beyonce, there are actually techniques and strategies to protect oneself. So what they've seen overall in broad brushstrokes is that when somebody has the ability to have reflective coping and problem-solving activities, that is the best way to help somebody through discrimination. So that means that they have a moment to say, this is what happened to me, and not have somebody say like, oh, well, maybe you got that wrong. They just need to hear like, this is something that happened to me, and thank you for listening, and then thinking about steps to move forward. So that helps them center themselves in that moment and then think about, how do I strategize about how to like keep going? They also saw the importance of community and central identity, and noted that social support, spirituality and religion, humor, role shifting, cognitive reinterpretation, even withdrawing for self-protection was also beneficial. No, Chase, we need some specifics. So there's actually an article by the APA that is called Disarming Racial Microaggressions, and this can apply, and we actually teach the kids this when they're going through things. So the first is making the invisible visible. So naming the discriminatory behavior that you saw, you name the behavior and not label the person as racist. They've done studies, and if you name, if you call somebody racist, it actually like shuts down the conversation and can make them do this thing where they double down and they will like try to prove that they're not racist and then do more racist things. So you name the behavior and say like this was a racially charged behavior. Also disarming the microaggression. So I don't agree with what you just said, being very clear cut and not engaging in negotiation back and forth. Also educating the offender. So all of these that I'm listing, they take practice because you can't just go into a situation and be like, I'm going to educate this person. It is about knowing and practicing beforehand. You need to know the room and who's around you and if it's a safe maneuver for you to use. So it's kind of like playing chess a little bit. They also saw that seeking external validation proved effective. So that's myself going to the vice dean when I was in medical school. She's still one of my best friends. And we actually text each other. And she heard that I was giving these talks like years ago. And then recently texted me to say like how proud she was. And she's read every article that I've written. So she was somebody who got me through med school and did such a beautiful job. And she's like straight and white and like very short and just like wonderful. So seeking external validation and intervention can be helpful. There's also redirecting and reframing, which can be beneficial too. So this is the article, and they actually like made a whole chart out of everything that I can send to people if they want. So let's finish that vignette. How did that vignette that we began with end? So I flew to San Francisco and cried in my apartment that night from missing my friends, relief that I escaped an unsafe environment, and over the loss of my once dream to stay in Boston forever with my friends. Over the next weeks, I took time to myself to reflect, to look to the future. A few weeks later, I revealed my true identity on Twitter because I felt safe, and then I began my fellowship. Within weeks of my arrival, my depression and suicidality vanished, and I entered the third remission period in my life. I found a program where my program director said to me, "You never have to take on issues with racism if you don't want to. It is not your job to handle these things," and back that up with words and actions. I got to work with co-fellows who spoke up around instances of discrimination before I had to say a word, and I had the opportunity to work with mentors who looked like me, who focused on what really matters, helping kids, their families, and our world. After 7 years, I had finally found overall safety and broad support in academia. I began to fully live again. I got to again more fully become that unicorn phoenix nicknamed Dream by his friends years ago. I'm different, but similar in the important ways to me. I've had time to work on articles about minority stress, do lectures at other universities and at organizations like this one, engage around topics of diversity by choice and not for survival, skip down the street listening to K-pop, go gay clubbing, sit and simply breathe, build a family with old friends and new, and be fully present when I see old friends in Boston and my family in Seattle. I've been able to see just how far someone can fly when not constantly barraged by discrimination. I found an environment like the one I had in college and graduate school where I feel safe. The scars are still healing and it will take time, but those cracks are healing and I couldn't feel more fortunate. Because of all of that, I graduated 2 years ago from fellowship at UCSF and decided to stay as faculty, as an assistant professor. Some of you know what I've been shortening that assistant professor to. I'm not going to say it here because it's not appropriate, but like just assume what like assistant would be shortened to. Part of my work with others is being medical director for a program we built and are expanding specifically for minoritized youth that involves trauma-focused cognitive behavior therapy, healing from discriminatory trauma, and we're starting peer groups for the kids and parents around discrimination and mental health and collaborate with other clinics. In honor of the friends, family mentors, and people I love who saved my life once upon a time, the clinic is named after our group nickname that started in college and grad school, which is the Muses. Thus, our team is called the program that opened July 2023, the Muses Program for Minoritized Youth. And I'm excited to see where these new chapters I get to write with all of you take us. So this is with special thanks to a special person who's on this call right now, who has been a wonderful mentee and somebody I deeply admire in a lot of ways and is doing the work in ways that I would not have dared to do back in the day. So yeah. All right, that's everything. I do not know how to stop sharing on here.
Well, I'm crying, as everyone else. Thank you so much. Where to begin? First of all, for that sentiment, Chase, thank you. You have done far more than just inspire me today. And I know that to be true because I remember the effect that you had on me and a group of medical students when I first met you a few years ago, and how I felt the moment you started sharing your story. And I encountered like a deja vu of sorts listening to you today. And I won't speak too long because I want to ensure that others get a chance to share sentiments. But I want to thank you for your time, and above all, if there even is an above all, for also, can you see me? Or since your spotlight, can you see
I
nobody?
can see you. I just don't know how to stop sharing because there's like no button on here for right now. Oh wait. Maybe. Okay, got it.
There we are. You got it? Okay, hi.
That's okay. Good to go.
It's good to be able to, okay, know that you can see me. The vulnerability that you share throughout your journey, and I think it's so unique to have anyone, especially a physician, come in and share. Oh, hello. Thank you. I am I am present. Listen to me now. But to have you, you know, to encounter someone with such honesty. Oh, both of us now. I love it. Um, it is so rare to have a space to hear someone so vulnerably talk about what they have gone through and how that has contributed to the way that they show up in medicine and the way that they show up as a person. And so I just want to thank you before we open the floor, for being an exact, symbol, personified of what we need, and of what we're again hoping to achieve as future clinicians. So yeah, I'm like emotional. Okay, everyone else who would like to be spotlighted? Thoughts, reflections.
And I know sometimes this is a lot for people to sit with because some people will be like, this has been my whole life and I didn't have terms for it. Other people will be like, this is what I've gone through and now I need to figure out what to do next. So it is also okay to email me questions later as well.
Thank you for saying that. And I think also due to the gravity of the topic, and perhaps someone here or someone listening in on the streaming service might have also had, right? It's very likely that someone else has encountered minority stress and or suicidality, depression, anxiety. And so we understand that this brings up a lot of emotions, and we're here to process with you, and we won't be, I won't close the Zoom out exactly on time either. We'll be here to listen.
Here to help and here to support.
Dr. Anderson, I have just so much gratitude for what you've shared today, and sharing your narrative in particular, with the vulnerability that you did. Thank you for that. It's a gift to be able to encounter someone who is both willing to share and has worked on the language that allows that person to share in the way that you did. One of the things I think a lot about, both in relation to my own experience of bullying through all of my primary and secondary years for my non-normative masculinity, in the context of a Christian school where apparently Christian love is supposed to be practiced on the day-to-day. But I think a lot about, both from that perspective and just from the awareness of how many students experience educational spaces as spaces of violence, spaces of dehumanization, and spaces of delegitimization. And that is especially true for students who have aspects of their identity that are minoritized or pathologized. How do you think about the norms of medical education with an awareness, through an anti-oppressive lens, through a lens of trauma-informed practices, both with respect to the fact that pre-med and medical students are traumatized from the earliest experiences in this journey into the profession, and then also are proximal to so much trauma in the capacity as a physician or in the capacity as a care provider. how do you think about all of that, and how do you think about the answers to that? As somebody who is involved in AMSA's national programming, developing our curricula in different programs, one of the things that we've been intentional about is writing a new agreement of care practices for adult learners, recognizing and acknowledging that the individuals that we work with and encounter are specifically our adult learners, who are infantilized by their own medical schools almost without exception. Share your thoughts on some of that, if you don't mind.
I know, of course. And thank you for sharing those parts of yourself as well. And I think the first thing I think about is why are we not naming it specifically? I think that is something we do very poorly in medical education, not everywhere. And of course, I do not want to broad swath things. However, we do not talk about how we treat people in medicine. We try to hide it. We try to brush it under the rug. We try to blame those individuals. Those individuals get fired. They get kicked out of medical school for speaking up. To have a voice is sometimes to be asking yourself to be silenced by the medical system. And so how do we ensure that people are able to have their voice and that administrators are the ones doing the work too, to name exactly what's happening at their universities? Because when medical students do it, it leads to what we just talked about, where they burn out and they leave. I have left 2 universities and it was painful every time because I would sometimes think I'm the problem. Like I came here to be a solution. I am a problem. And now those people are apologizing all over the place, but like it's still one of those, we forget how much people take home with them and how sad it can be for somebody to think that they are a problem. And so naming that the medical system does that is, I think, where we start, and being honest and upfront of saying, that's why I have those statistics in this talk to say, like, this is what happens to people. This is what we are doing to people. And so how do we weave that into medical education early on so people coming in are not disillusioned in a different way later on when they experience those things, and give them the tools that they need early on? Because I think one thing that was really hard for me in medical training was at the beginning, I had come from MIT and like, yes, there were issues at MIT. However, I had unraveled all the things that had been learned in high school and like patterns of behavior that I had to like use to survive. All of those like came back very quickly, and I had to build new strategies to just get through the day. I don't talk about it much, and I'm figuring out how to be more open about it, but I was suicidal every like 30 minutes in medical school sometimes, and like had intents and plans and everything. And I didn't want to scare people when I first started sharing this. And I've been very careful and meticulous about how I do share. And now I'm more comfortable where I'm like, yeah, I was suicidal all the time. But that is what happens to people. So how do we help them by knowing this is what might happen with mental health? This is what might happen with like the legacy of abuse that we have. This is how we're trying to fix it, and this is where to go if this starts happening to you, so you don't have to build a playbook by yourself, basically. That was the thing that was scariest, was experiencing things from classmates thinking I was a problem for speaking up. And then I would go home and I would strategize, like how to handle things. And I was like, I don't think I'm doing this right. And I would stand in the shower for an hour in the morning sometimes, and I would plot out exactly what classmate, like who knew whom, what classmate had said what about diversity, what dean I might have to walk past in the hallways and how they handled things around discrimination, who I could push with, and all that stuff. Like, is there a way to teach people, like, you don't have to do all that maneuvering because here are the safe people to go to, is another thing that I'm thinking about. And then as we start to heal, one of the things that we will notice is there will be an extinction burst. We're seeing that in some ways in America, where when you start challenging patterns of behavior or trying to establish new behaviors, you see that the behaviors get worse. And so how do you also navigate that? Like in some ways, where as the university starts changing, how do you contend with the people who do not want it to change because the system is built in the way that benefits them and is not benefiting everybody? It's like a bigger question than what you like that you're talking about too, but those are some of the things I've been thinking about.
Thank you.
Curious how this resonates with others, and please, as Chase so beautifully mentioned at the beginning, there is no, um, we feel your presence, and so whether or not that's in spoken word or text here, that's okay. I just want to share something that resonates to me as a student that was working heavily and still is in some ways on the wellness practices that are enacted in our medical schools. And a lot of what, the word that stands out to me is visibility, right? And that way. So it's like you mentioning your story of maneuvering and all of this being this internal process that is essentially isolating in and of itself, right? Because you're not sure who else is asking themselves these questions. Who do I go to, like you said? And how do we make visible the structures from the onset, right? From the first day of medical education. Hey, this exists. We exist because these problems happen. These experiences, these human emotions occur. We are here, and then at intervals reappearing, so that visibility creates a sense that you're not reaching into the depths of something that doesn't exist, or that it shouldn't be talked about, or that you're alone in. So that really stood out to me.
I think the other thing I would add to Jeff's question earlier too, and to what you just said is, where do people get to process this? Because some groups, I remember we would have small groups, and mine were with white classmates where I wrote an essay about things that people had been saying, and I was blamed and told that I was an issue, as well as what was the other thing that really got me? Oh, people need to be careful about how they label racism when things are not actually racist. So those were things I heard from classmates. So when you build those groups for people to actually discuss, how do you build in safety for the discussions as well? Is something I think about.
Thank you.
Along those lines, um, there's when in medical education, I'm trying to think of how to like talk through this. In med ed, when we talk about health inequities, we are oftentimes pathologizing the very people who are the targets of the systemic oppressions themselves, the systemic violences that lead to the health inequities. And then medical students who are themselves minoritized suffer in some ways they suffer from a double-edged sword in that they are in that the way that medicine talks about health inequities is to pathologize the person or the communities. And so Black students in medical school learning about health inequities that particularly pertain to Black people are, I think, doubly harmed because and so I'm wondering, and I think about this in relation to my own experience as a gay man, how especially a gay man who grew up, as a young person in the 80s and 90s, where so much of gay identity through a medical lens was about largely about harm, about HIV, about the risks, and like what I came to kind of think about myself as I was coming out in medical school as a gay person was, why am I the problem? I'm not the problem. So, yes, behaviors can lead to things like HIV infections and all of that. So yes, I want to be careful. I want to care for myself. I want to care for others that I am engaged with in any form of connection, relationality, or intimacy. But I'm not the problem. So in your experience, Dr. Anderson, how have you dealt with that sort of dynamic of recognizing that the way that we talk about health inequities in medicine itself is problematic?
Go back to naming it. This is part of, I have an expanded talk that adds other slides, but one of the things I talk about is like even how we do our one-liners. I'm always like, why do you mention 38-year-old African-American person? Are you possibly predisposing people before they enter the room? Because I have noticed that notes do not say 27-year-old white person. So how are we even documenting? The other thing is, how do we talk to patients about the harms that the medical system has done? The other thing is you saw me do this during the talk, but with the minority stress framework where I was like, I use the word minoritized so kids know, and I specifically name like you did not cause these problems. And in medical education, I remember going to class and one time somebody was like, we were listening to all the things African American people went through, and they looked at me. It was my roommate, actually, or one of them. She was like, "It's a wonder you're alive." And I was like, "Oh," like it was just such a weird comment. And then also, but then I was like, "Oh yeah, it is kind of weird I'm alive because like why don't I have heart disease right now and like all these other things." And the other thing that got me during lectures was it wouldn't say this is like African Americans have higher rates of heart disease because of discrimination. We are shorthanding a lot of things that I think we think in the medical system that people cannot handle depth and like nuance. And so we teach each other, do shorthand that is making us more problematic in a lot of ways. So why are you not adding half a line to say this group experiences discrimination, which leads to this? So like we are changing our language in the medical system, I think, and that's what needs to happen. So I may have to step off because I have a patient in just a
Yep.
second.
Yep.
So,
That makes sense. Go be great. Wow, thank you so much. Thank you so, so much for continuing this journey today for us. And Chase, we love you at AMSA. We love you. I love you. We all love you. And we hope for further conversations on this with you. You are always, you know, greeted and welcomed with open arms. So best of luck in your lucky patient encounter for this patient, and we'll see you soon. I'll close out for the rest of the group too, but feel free to go. Do you want to enter in your email maybe just before you go? That would be great. Thank you so much. Wonderful. We'll see you soon.
and nice to meet all of you.
Thank you. Guys, thank you so much. That was another incredible discussion. So sorry if you didn't get a chance to share any thoughts and reflections. So we'll, of course, I'll be staying online for a little to hear if there's anything on your hearts. Please do take note of Chase's email if there's anything that you feel like you didn't get to ask. He's doing some incredible work. Some of his work is actually on the HEWA landing page on the AMSA website. When you click under day 2, you can see some of the things that he's written. He's very beautifully public and loud with his pride surrounding these issues. And so please take a moment, if you can, at some point to read some of his work. But I'll pause and encourage if there's any other thoughts, emotions to name, needs. Okay, so what we'll do now is do a little closeout. So we learned a lot today, whether you were only here tonight or in the previous session, or just tuning in on the stream, whatever it might be. Today we face an abolitionist framework yet again on day 2 of Health Equity Week of Action. We ask the difficult questions, we listen to the answers with compassion, and we think of more ways that we can be the change that we are hoping for. Not to sound like a Hallmark card, but it's true and it's real, and we hope here at AMSA, here at the team with Reach and Jeff and all of our lovely ones, and thank you, Pete, for navigating everything behind the scenes. We hope that you'll take something special away from these talks, and in light of that, there is the journal that I shared in the chat. Please feel free to, if you have an iPad, you can write down. You can also convert it into being able to type in it. Hopefully that works for you. If not, let me know. There is a survey at the beginning of the journal if you have not yet participated. I would really appreciate it. and we hope to see you for day 3 tomorrow. We will be looking more deeply at trauma-informed care practices with the wonderful Dr. Taylor Brown, who is a clinician and also a professor at Harvard, working to do more necessary unraveling regarding what's called TIC, trauma-informed care practices. We'll get the chance to even do a little mock breakout situation. She'll teach us more about how to turn towards these difficult conversations and how to do more mindful physical examinations that keep trauma at front of mind and keep care at front of mind. So tomorrow, that begins at 4 p.m. Eastern. We love you, and we'll be here if you need anything. So I'll be on for a couple